Hi everyone, Whitney Lowe here, and I'd like to welcome you to another one of our Clinical Insights videos. Today we're going to be talking about carpal tunnel syndrome. It is, of course, the most common upper extremity nerve entrapment problem, and it's one that massage therapists can do a great deal for and help address a lot of the pain complaints that your clients are experiencing. One of the interesting things about carpal tunnel syndrome is it's so prevalent, and yet there are a number of diagnostic processes and methods that are used to identify it, not all of which are really that accurate. And so one of the ways to get more accurate at identifying a nerve compression problem like carpal tunnel syndrome is to do a really thorough and comprehensive physical examination. So the sort of standard test that you might get at a physician's office for evaluating this would be something like a nerve conduction velocity test, where they're looking to see if there's a change in the speed of transmission of nerve signals through that region of the carpal tunnel. But sometimes those nerve conduction studies don't pick up other potential areas of problems with the median nerve or something that might be contributing to carpal tunnel problems. And then they'll come back and say, well, you don't have this, but in essence, there is still something going on with the median nerve. So today I want to outline a couple of ways to sort of enhance your clinical reasoning and look at some ways to evaluate carpal tunnel syndrome with some variations on a number of the standard orthopedic tests that are frequently used to address that. So what we're going to do is we're going to look at some of those common orthopedic tests, and we're going to look at some different ways to sort of modify or tweak them a little bit to make them even more versatile and more sensitive to identify some of the different things that you're looking at. Now, the first place I want to start is I want to take just a brief moment to look at some anatomy, just a quick picture of the median nerve to remember its pathway so that we can understand what's happening during some of these different tests. So let's take a quick look at that. So here's a schematic representation of the median nerve. You'll notice it's coming out of the shoulder region here, coming down through the upper arm region and across the anterior part of the elbow. And what that means, since it crosses the anterior part of the elbow, is that when your elbow is in flexion, that nerve is going to be slackened somewhat in this area. So it's going to decrease tension on the overall median nerve. As you move your elbow into extension, that nerve is going to get pulled taut a bit more. Also up here in the shoulder, when you bring your arm all the way out here in abduction, that's going to stretch that nerve a little bit, as it will if you bring it up into full forward flexion, raising your arm up overhead. So those two positions are also going to stretch that median nerve. Now, if we come down here and look at the wrist region, we'll zoom into a little bit closer here. Notice that we've got the median nerve coming across the carpal bones, and this is the area where the carpal tunnel is. Remember, we've got some connective tissues binding across here, and that's what makes the tunnel that the nerve goes through right here. So if you move your wrist into flexion like this, moving your wrist into flexion, that nerve is going to be slackened a little bit in that tunnel region, but also there are some, because of the binding connective tissues across here and the contents of the carpal tunnel, there's quite a number of tendons that also run through that tunnel. You're going to further compress that nerve when you move your wrist into flexion. If you move it into extension in the opposite direction, you're going to pull this nerve taut across those bones and will kind of bowstring that nerve in the carpal tunnel. And that's also likely to increase some irritation on the nerve in the event that you have some type of nerve pathology going on. So I want you to keep in mind the pathway of the median nerve as we look at some of these different positions that are used for some of the common assessment procedures and what we're going to do to change them. So let's go take a look at that. Now, perhaps the most common orthopedic test that's used to evaluate carpal tunnel syndrome is something called the Failin Test. We can see an image of the Failin Test here. It's performed by sort of bringing your arms and shoulders up into abduction. Your elbows are flexed, and you press the back sides of your hands together. So by holding them in this position, you are compressing the median nerve in the carpal tunnel. Now, with most of these procedures that we're going to be looking at, the main thing that you're going to look at is, do these symptoms arise within about 30 to 60 seconds? So once you're holding your wrists up in that position, you'll hold that for about 30 to 60 seconds and see if it reproduces neurological sensations in the palm of your hand where the cutaneous distribution of the median nerve is. Now, this is quite important to note where those symptoms are felt, because there's a couple of different nerves that innervate different parts of the palm. Now, if you get symptoms of median nerve compression, note where those symptoms are felt. They're usually going to be felt in this area right here, designated in this particular image with the C6 and C7 dermatomes. The C8 dermatome is fed by the ulnar nerve. So if those sensations are on the back edge of the hand here, this is not likely median nerve compression. So we're going to be looking mainly for sensations sensations in this part of the hand right here on into these fingers because the branches of the median nerve that are affected here in the carpal tunnel are coming out of those particular dermatomes. So those are fibers coming from the C6 and C7 nerve roots. Now, because the elbow is flexed in the standard Failin's test, the median nerve is a little bit slackened across the elbow. So this test isn't quite as sensitive if your condition's not really bad. So one of the ways that we can enhance that a little bit is to stretch the nerve across the elbow. We could even stretch the upper portion of the nerve by tilting the head to the other side. So if we use that Failin's test position with the wrist bent in flexion, and then we also straighten the elbow out in extension and laterally flex the head to the opposite side, this is a variation that could make that Failin's test position a bit more sensitive. Now, obviously, as you can see by this image, we would do this on one side at a time, as opposed to, you're not holding both hands together like you are in the traditional Failin's test. But this is a good way to use a variation that might make that test a bit more sensitive. Now, another procedure that's frequently used is called the pressure provocation test, and that's fancy name for just saying pressing on the carpal tunnel. So you're pressing on the area of the carpal tunnel to see if those nerves are hypersensitive. Now, obviously, you want to use caution when doing this and not press hard in this area, but if a mild or moderate level of pressure elicits a really serious pain sensation into the hand or reproduces the sensation your client's been experiencing, that's a good indication that there might be some median nerve sensitivity in there. Now, one way we can sort of vary that a little bit is do kind of like we did before with that last variation. Here, we're going to use that pressure provocation test by pressing on the base of the carpal tunnel region, but this time we're doing it with the elbow extended, once again, bending and pulling the nerve across the elbow joint, and then laterally flexing the head to the opposite side. That puts tension on that median nerve all the way through the pathway of the median nerve, and so that's going to increase the sensitivity of that test, and therefore we don't have to press as hard, but we can also get a sense of what level of pressure is causing those symptoms to be aggravated more significantly. Another common procedure that we see used is called the hand elevation test, where you basically just raise your hand up overhead like you're wanting to ask a question, hold it up there for about 30 to 60 seconds, and see if that reproduces the sensations that the person has been experiencing. Now, we can do some slight variations on that hand elevation test, just like we did before, by simply tilting the head to the opposite side, and note how that stretches the upper portion of the brachial plexus. So that brachial plexus that's just feeding into the median nerve, that brachial plexus is coming down the neck, going underneath the pectoralis minor muscle, basically taking a completely 180-degree turn, and then now heading back up as it goes down the length of the upper extremity, which you're holding overhead. So you're kind of bowstringing the upper portion of that median nerve, and this can make that test a bit more sensitive when you bend the head to the opposite side. The last one we're going to look at is a variation on something called the tethered median nerve stress test. Now, if you focus for a second on this picture, just at the area down around the wrist, this is mainly what we look at when we call the tethered median nerve stress test. So we're looking at what's happening with the hand and wrist. We're going to bend the wrist into hyperextension and hold the index finger and pull that index finger down into extension and see if this reproduces those sensations. Now, this is often done with the rest of the arm and the head in a bit of a neutral position. But if you want to make this test a bit more sensitive to see what's going on here, you can add in there the elbow extension that we've done in a number of these other procedures, and also the lateral flexion of the head to the opposite side. That's going to help pull on the upper portion of the brachial plexus, again, and putting tension throughout that entire pathway of the median nerve, making that nerve a bit more sensitive to the levels of tension stress that are placed on it during the tethered median nerve stress test. Now, one of the other things that I want to emphasize is you don't want to do any of these tests in isolation. This is one of the big problems and sort of objections that I have about the way that a lot of these special orthopedic tests are popularized. People tend to just, look up tests and say, oh, I'll do the so-and-so test and see if this is, positive or negative. You've got to remember any of these tests are not done in a vacuum and not done in isolation. You're doing this in conjunction with the other critical parts of your evaluation process, which include a comprehensive and detailed history, which is so extremely important, looking at various factors and observation, palpating tissues, and going through a comprehensive physical examination. You might be testing active movements, passive movements, and some resisted movements also, to see if the whole clinical reasoning process and picture paints an outline of something that does look like nerve involvement. So these are some of the key factors that you could look at to get a good sense of whether or not this is something that might involve median nerve pathology. So this is your quick tip on looking at some variations on carpal tunnel evaluation processes. There's another way that you can, use some good resources to help you get a good sense of what might be going on with various different tissues. We've got a great cheat sheet that's available to you. You can find that over on our website at academyofclinicalmassage.com/cheat sheet. And that cheat sheet gives you a quick way to look at some of the common signs and symptoms associated with a wide variety of the most common soft tissue disorders that you're likely to experience. So hop on over and grab that cheat sheet. It's a great way to get a good jump on helping to evaluate what might be going on with some of your different pain complaints that your client's experiencing. All right, we'll see you in the next go round.